Today's topic is regarding drug dosing in kidney dysfunction. Basically, I'll be speaking about what are the changes which can happen in levels of drugs in patients with AKI, CKD, and and what all we should know about the drugs and how it can affect the therapeutic effects or toxic effects. So, coming to introduction, so chronic kidney disease affects around 10 to 15% of the world population, and its incidence is doubled in adults who are more than 65 years of age. And acute kidney injury affects around 2% of the hospitalized patients, and the incidence of the AKI in ICU is 30 times more. And as the AKI occurs in ICU, the mortality of these patients is also very high. Why is it important? This incidence tells us that AKI or CKD is pretty common, and all these patients who are having this AKI and CKD are more prone for hospitalization, and they will be given multitude of drugs. And if we give the drugs at same dosage as we give to normal people, they can have less effect or more effect or more of side effects. So this is because AKI and CKD they uh, change the pharmacokinetics and pharmacodynamics of the many drugs. And this is because of the pathophysiological changes which are associated with kidney dysfunction. Along with this, renal replacement therapies can also affect the drug levels. So, medications which are predominantly excreted unchanged by kidneys may accumulate in kidney disease. So, where does this dosing come from? For this creatinine clearance or GFR, what drug dose to be given or at what interval will be given is provided by the product manufacturer. There will be a package insert in which, for this specific GFR, this much dose should be given is mentioned. So this is the best source for the drug dosing. This is because the manufacturer who has produced or manufactured this drug will do studies on patients with kidney dysfunction. So this product label drug dosage is based on studies done on few patients and not all the patients with kidney dysfunction, and sometimes it is done post marketing. So at the time the drug is released, many of the drugs may not have dosage adjustment for kidney disease patient, and they will outright mention that we don't have data, and sometimes it is contraindicated in these patients. So, and they will be labeled as not indicated in patients with renal dysfunction with a specific GFR. So this precludes the patients with kidney dysfunction for the beneficial effects of these drugs. So for example, if we take between 2002 and 2007, only 57% of the new drug applications to FDA examined the pharmacokinetics in kidney impairment. So rest of the 43% doesn't have any data about this pharmacokinetics in kidney impairment. So we cannot tell about the dosages of these drugs in patients with kidney impairment. So, and one more issue is the majority of the data which is available currently is based on studies done before 2000 for the drugs, and it is based on a formula for creatinine clearance called Cockcroft-Gault formula. So I'll be explaining more about this in the later slides. So what are the reasons to optimize dosing regimens in kidney dysfunction? So there are two reasons. One is subtherapeutic dosing and other one is supratherapeutic exposure. So both of these can occur. So if we don't optimize the drug dose, there will be increased risk of treatment failure if we dose the drug less, and this may be problematic in certain conditions like in infections or in autoimmune conditions where we give anti-infectives and immunosuppressive drugs and we want maximum effect at the initial period. So if we don't adjust the dose, there may be subtherapeutic dosing, and effectively the drug may not be effective in these patients. And another one is the supratherapeutic exposure. If we give at normal dosages in these patients with reduced kidney function, active or toxic metabolites can accumulate, and that can lead to more of toxic effects. So we don't want these two things. So because of these subtherapeutic dosing and supratherapeutic exposure, we want to avoid this and we want to adjust the drug dosages in patients with kidney dysfunction. So coming to stages of chronic kidney disease, here I wanted to concentrate on the criteria which we use for diagnosing or staging the CKD. Here it is EGFR. So GFR is calculated by some formulas, which I'll be telling later. So based on that, we stage the kidney stage the CKD, stage 2, 3A, 3B, 4, and 5, respectively, according to the GFR. But when we come to AKI, we don't have the GFR here. Here we have only creatinine and urine output. So stage 1 is up to creatinine 1 to 1.5 times of the baseline, 2 is 2 to 2.9, 3 is more than 3 times, and based on the urine output. So why is this? So this is because for CKD, we assume that the creatinine is stable over a period of time, so that we measure the EGFR based on the formulas which are developed in patients with CKD where the creatinine was stable. But in AKI, the patients are dynamic. The GFR which is present now may not be present next minute or the next hour. So we cannot use EGFR in diagnosing AKI. So here comes the problem of dosing in patients with AKI where we don't know the GFR, how to dose them. So the GFR is calculated by three important formulas. First one is the Cockcroft-Gault formula, which was developed in 1976. The parameters which are used are age, serum creatinine, sex, and weight. And it was derived from a small subset of population of 236 patients. And the advantages are it is convenient to use. And this is the predominant formula which is used till now for dosage adjustment in kidney dysfunction. So the limitations are, before 2010, the standardized creatinine value was not standardized. So there was lab to lab variation. Now, if we compare the creatinine values which we have now, which are standardized, the creatinine values before are 10 to 20% higher. The GFR before were 20 to 20% higher. So the data which is present on the drug dosing based on the creatinine clearance, which was calculated by Cockcroft-Gault before, was totally different from the EGFR values which we have now. And the formulas which we are having now are more accurate when compared to Cockcroft-Gault. But because there is no data available based on the new GFR formulas, we still have to depend on the Cockcroft-Gault formula for dosing. And one more issue with the Cockcroft-Gault formula is it underestimates the kidney dysfunction at severely reduced kidney function. If the GFR is low, Cockcroft-Gault formula will tell that it is much lower. If we use the other formula, the GFR will be little higher. But if we use Cockcroft-Gault formula, it will tell it is still little lower. So this we need to keep in mind. The other formulas are MDRD and CKD EPI, which is developed in 2009. CKD EPI is now the recommended GFR formula, which is advocated by KDIGO to be used in all patients for CKD. So, but it is not used for determining most kidney drug dosing recommendations. So here one more important point which we need to keep in mind is the adjustment for body surface area. So whenever we put the values of age, serum creatinine, sex, and race in the CKD EPI formula, we get a value of EGFR, which is per minute, EGFR of some example, ml per minute per 1.73 meter square of the body surface area. So body surface area is calculated by this formula. So if we want a GFR of a specific patient, we need to calculate the body surface area of that patient and divide it by 1.73 and multiply it with the GFR which we get. So that will give the GFR of that specific patient. Okay, so which we usually don't do in the clinic. So and this will be important in the next slides. How it will be important. So coming to the pharmacokinetics and pharmacodynamics, pharmacokinetics is what the body does to the drug. So drug is absorbed, it is distributed, metabolized, and eliminated. Pharmacodynamics is what the drug does to the body. So in this talk, I'll be concentrating more on the, or in fact, exclusively on the pharmacokinetics part, which is a major determinant of the drug dosing. Pharmacodynamics is little more complicated and it is as such a whole different topic. So I'll not be touching about the pharmacokinetics, pharmacodynamics today. So this graph shows the plasma concentration time profile of a drug after administration. Here the x-axis shows the time post ingestion of the drug and the y-axis shows the plasma concentration. So first one is the absorption lag time. There is a lag after we give a drug between the between the absorption and the administration, and after that the levels increase and it will reach a maximum level which is called Cmax. And after it reaches the maximum level, the levels will decrease, and this is the elimination phase. The initial phase where till the time where the drug reaches the Cmax is called the absorption phase, and the next one is the elimination phase. And the time which is taken to decrease the concentration of the drug by 50% is called the elimination T half. This is the elimination T half. So the important definitions which we need to know before knowing about the effects of kidney, the drug dosaging, are bioavailability, volume of distribution, and clearance. So what is bioavailability? Bioavailability is a fraction of drug that reaches the systemic circulation after administration. As we all know, 100% bioavailability is seen with drugs which are given with intravenous infusion. So if we want to know the bioavailability of a specific drug, we need to compare it with the AUC of the intravenous administration. So absolute bioavailability of a drug is derived by this formula by dividing the AUC after giving oral drug and comparing it with the AUC after giving intravenous. Coming to the next one, which is the volume of distribution. As you all know from our pharmacology days, volume of distribution is a theoretical volume in which the drug is distributed in the body. So if a patient has a drug which is more lipophilic or more attached to the tissues, the drug will be more distributed into the tissues and less of the drug is present in the blood. So in such patients, the volume of distribution is high, whereas the drugs which are more bound to protein are more restricted to the intravascular volume. There the volume of distribution is less. So the volume of distribution, so the maximum concentration which is attained by the drug will depend on the volume of distribution. It also depends on the absolute bioavailability and also the dose which we give. So if the volume of distribution increases, the maximum level in the blood which we get is less. And if the bioavailability is more, the maximum level is more. And if we give more dose, the maximum level is more. Coming to the clearance, clearance is the volume of blood that is cleared of a drug in a period of time. So it is the parameter that most closely describes the drug elimination. So clearance of a whole body includes the clearance from the kidney, clearance from the hepatic part, and clearance from the other organs. Like there are many other organs like intestines, skin, brain, muscles, where all metabolism can happen. So this clearance will determine the maintenance dose rate of a drug required to achieve a target plasma concentration. So if the clearance decreases, it means that we need to change the maintenance dose of this drug. So this graph shows on the x-axis the GFR. So as we move away from 0, the GFR decreases, and the y-axis shows the total drug clearance. Okay, this is the 100% clearance and the 0% clearance. So the blue line depicts a drug A which is cleared only by kidney. So the blue line. So if everything is simple, if the GFR falls down, the clearance of the drug also should fall down. It should be a linear line. And if the drug is excreted only by non-kidney clearance, like by this black line, so if the GFR falls also, the drug clearance should not be affected. It should be at the same level. So, but this is not the case. So I'll be explaining that in the next slides. So what are the alterations in the pharmacokinetics which can happen in kidney disease? So the first, if we take absorption, normally in patients with kidney dysfunction, there is increased gastroparesis and delayed gastric emptying, because of which there may be abnormalities in the drug absorption. And also there is increased gastric pH. This is because the urea which is elevated in these patients is secreted into the saliva, and this saliva, urea which is contained in the saliva, is converted to ammonia inside the stomach. So this ammonia will increase the pH level, so this can alter the drug absorption. So if we take these initial 3 parameters of gastroparesis, delayed gastric emptying, and the gastric pH, we think that the drug absorption is delayed in patients with kidney disease. But other things can also happen in the absorption at the absorption level. First one is the first pass metabolism. The first pass metabolism is First pass metabolism happens at the intestinal level and at the hepatic level. So in patients with kidney disease, there is reduced intestinal drug metabolism. So, and there is increased abnormal peak glycoprotein mediated transport. Both of these two changes can increase the bioavailability of the drugs. So, in patients with kidney disease, if we give an oral drug, the drug may be the drug level bioavailability may be decreased or increased based on the drug and the metabolism of that specific drug. Coming to distribution, after the drug is absorbed, it is bound to plasma proteins. Acidic drugs are bound to albumin, and basic drugs are bound to alpha 1 acid glycoprotein. So, in patients with kidney disease, or specifically in patients with AKI, there is decreased levels of albumin. So, if the albumin is decreased, there is less binding of the drug to albumin, and more of the free drug is present. And if the more of the free drug is present, it is more eliminated or metabolized. And if there is increased alpha 1 acid glycoprotein in patients with AKI or in sepsis or in SIRS, there is increased binding of the drugs to this alpha 1 glycoprotein. So this leads to decreased metabolism. And in patients with AKI or in CKD, there is volume overload. Volume overload can be in the form of edema or ascites or effusion. So this increases the volume of distribution. So volume of distribution can also be affected. So in kidney disease, there is abnormality in absorption and also in the distribution. Coming to metabolism, so metabolism which can happen in other organs other than kidneys can also be affected by kidney disease. So in CKD patients, there are studies which show that the metabolism with cytochrome P450 or other cytochrome enzymes is abnormal in the liver or at other organs. But in AKI, early stage it may be preserved, but it is still lost in the later stage. And coming to elimination, I'll be telling that in the next. So in this slide, if we, this is the kidney clearance. So this is the image of a nephron. This is the glomerulus. This is the proximal convoluted tubule. This is the ascending and descending limbs of the loop of Henle. This is the distal tubule. So what will happen in the kidney? So whenever blood comes with a free drug, it will get filtered at the glomerulus level, and the drug may also be secreted in the proximal convoluted tubule, and it gets reabsorbed in the distal convoluted tubule. It is not for every drug. Each drug may have different components, as we see here. So glomerular filtration, majority of the drugs, they get filtered by glomerular filtration. But if we take the proximal convoluted tubule, we have two transporters, that is the organic anion transporting polypeptide, organic cation transporting peptide. So this will secrete these drugs into the tubules, like beta-lactams, antibiotics, statins, and metformin. They are secreted in the proximal tubule by these transporters. So let me give an example. In a normal person, if we take benzyl penicillin, 30 to 50% is filtered at glomerulus, but 50 to 70% is secreted by organic anion transport, and nothing is absorbed in the distal tubule. Whereas if we take fluconazole, 100% gets filtered, nothing is secreted, but 90% gets absorbed. So each drug has a different metabolism or filtration or secretion at the kidney. And why is this important? Because few kidney diseases can affect glomerulus, few kidney diseases can affect the proximal tubule or distal tubule. So if we have a disease which is affecting the glomerulus, the tubular secretion part can be intact, or distal absorption part can be intact, like in glomerular nephritis. But if we have an interstitial disease, the tubules may get damaged, but the glomerulus may be normal. So this also we need to keep in mind, because there are few conditions where the GFR was more than 90, but the clearance was decreased. This is because the glomerulus was affected, but not all glomeruli were affected, but the filtration was decreased. So these all are little more complicated and are important. So coming to drug clearance by metabolism, excuse me. So drug clearance by metabolism. So there are so many enzymes in the liver, enterocytes, or other organs of the body which will metabolize many of the drugs, like shown here: CYP2D6, 3A4, 1A and 2B6. Like these are the drugs which are metabolized. These are not metabolized in the kidney. For this, for example, this caffeine, theophylline, these are metabolized in the liver. But what happens in patients with kidney disease? There is decreased metabolism, or sometimes it may be increased also. So, kidney not only affects the clearance at the kidney level, it will also affect the metabolism at other sites in the body. So, this is shown in this graph. So, these are all the drugs: theophylline, bosentan, omeprazole. These are not excreted by kidneys, but what happens is, as the GFR decreases, the metabolic clearance is decreased in these drugs with these drugs. So kidney affects the metabolism at other sites in the body also. But we cannot quantify that at present. What level it is decreased, what is the effect on the drug and all, we don't know currently. So we cannot use it at the bedside. One more concept is the augmented renal clearance. Augmented renal clearance is the presence of higher GFR in the initial phases of sepsis, burns, and trauma. This happens because of the increased blood flow to the kidney because of the hypercirculation. So, what will happen? So, if we have more GFR, sometimes the GFR can go up to 190. So, if we give the drug at normal dosages, thinking that the kidney is normal, it will be more eliminated and less effective. So in the initial phases of the hyperdynamic circulation, we need to consider the augmented renal clearance, and this can be identified by measuring the urine from 8 to 24 hours. We need to measure the urine of 8 hours, calculate the creatinine in that urine, and calculate the creatinine in the measure the creatinine in the blood, and by UV by P formula, we need to measure the creatinine clearance. So this will tell us about the augmented renal clearance, which is also an important concept, especially in patients with sepsis. Coming to the last concept, which is the elimination T-half. So we all know that T-half determines the duration of the action of the drug, and it will also tell how much time it will take for the drug to reach a steady state plasma concentration. It is usually 3 to 5 plasma T-halves, and it will also tell us about the dosing frequency. So the T-half is given by this formula of 0.693 into volume of distribution and clearance. So concentrate in the next few slides. These are a little more complicated. So if the clearance decreases, according to this formula, if the clearance decreases, for example, let us take if the clearance halves, so the T half will double. If the volume of distribution doubles, even then the T half will double. Okay. And T half, which we consider should not be only of the parent drug, but also of the active or toxic metabolites. This also we need to keep in mind, because morphine, allopurinol, and glyburide will have active metabolites which may reach the toxic levels if we don't adjust the drug dosing based on that toxic metabolites also. So concentrate on these slides. So here the x-axis shows the time post ingestion after the drug, and this is the plasma concentration. And the blue line shows the graph where there is doubling of the volume of distributions. As I've already told, if the volume of distribution doubles, T half doubles. And the red line shows the clearance is decreased. If the clearance is half, the T half also obviously doubles. So the same happens here. So in this, and the black line is of the normal kinetics. So if the clearance is half, what happens is the T half is doubled, okay, but the area under curve is totally changed. The area under curve doubles, it increases by 100%, and the maximum peak also increases. Whereas if we double the volume of distribution, this blue line, the peak concentration decreases, T half doubles, and the area under curve is same. So this is important. So if we don't take into consideration these changes, and if we give the drug at the same interval if we are giving the drug, in the normal person with the black line, the drug will reach the baseline. If we give again, it will increase in the level and it will reach the baseline. But in patients with doubling of the volume of distribution or a halving of the clearance, you can see that the levels gradually accumulate, especially in patients with a clearance where it is decreased. The levels will go very high to toxic levels when compared to volume of distribution where the levels still go high. So here what we need to do, as I've already told, as the T half doubles, we need to adjust the dosing. So if we double the time period, at which we give the drugs. So the black line we give at the same interval, but in patients with volume of distribution doubling or with halving of clearance, here we dose the drug at double the normal time. So the drug will reach the baseline level and it will again reach a peak and it will reach the baseline level, it will get eliminated. So this is important. Still here, the peak may be abnormal when compared to normal kinetics patient. So this is important when deciding what drug to be given at what dose, which I'll be giving examples in the next slides. So when should dosing regimen be adjusted? So dosing regimen should be adjusted for selected drugs whose pharmacokinetics are affected by kidney disease, where there is high risk of drug accumulation and severe and irreversible toxicity, and to attain an effective level of drug doses in the blood to treat condition. So, and when dosing is not required. So dosing is not required when less than 30% of the dose is excreted by the kidneys, and if the clearance of the kidney is decreased by less than 50%. So these two things we need to keep in mind. And for some drugs with low toxicity, we can give it full dose if the duration of the treatment is very less, like for small antibiotic courses like 5 days, 6 days. So there we need not adjust the dose much. So coming to approach to drug dosing, the first approach is the start low and go slow approach. This we can use for outpatient conditions like diabetes or hypertension, where we are not worried about the immediate effect. So the gradually here in this type of condition, we don't give loading doses also. Gradually, after 3 to 5 plasma levels, 3 to 5 T halves of the drug will reach a specific level in the blood and it will show its effect. And the patient comes back to us and we'll increase the drug dose based on the effect and response. Here, even in patients with abnormal kidney disease, we can gradually start at low dose and gradually increase the level of the drugs. But this is not appropriate in some conditions, like in infections or autoimmune conditions or chemotherapy, where we cannot go slow or low because we want maximum effect at the initial time, without which we can have poorer outcomes. So these are the exit criteria. So what are the criteria which tells us that there is some problem with the kidney clearance? So these are the criteria given by a group called extracorporeal treatments in the poisoning group. So if these factors are there, these markers will potentially signify that there is decrease in drug clearance. So if the GFR is less than 45, or if the AKI is stage 2 or 3, or if the creatinine is more than 2 milligrams in patient without baseline, or if more than 1.5 in elderly, or if the creatinine increases more than 2 times the upper limit of the normal, or if the presence of oligoanuria. So all these markers signify that there is some problem with the clearance and we need to adjust the dose. So what is the design for dosing regimen? So important principles which we need to consider while giving a specific drug is to identify the target concentration which we want to get in the blood, the initial dose, maintenance dose, what is the frequency which we want to give, and when a dose adjustment should be done. So defining therapeutic target. So therapeutic target is the concentration. This is in this graph which shows metformin levels after administration of 500 milligram twice daily, or 1000 milligram once daily, or 2000 milligram alternate days in a patient with GFR 20 ml. So this is the target concentration which we want. So this is the therapeutic target which we want, and the therapeutic target depends upon the drug, what indication we are giving that drug for in a specific individual, because individual can have abnormal clearance, abnormal hepatic clearance, and the duration of the treatment. And as I've already told, antibiotic, immunosuppressives, and chemotherapy will require maximum effect at the initial dosages. So what is the target concentration which we should target for a specific drug? So this usually is based on the studies which are done initially on that specific drug by the companies for a specific disease. So that target concentration we need to, that is the concentration which we need to target. So coming to the loading dose. So loading dose is the initial dose which we give while starting, especially antibiotics or antiepileptics and some other drugs. So loading dose should we modify loading dose in patients with renal dysfunction? This is the question. So here loading, the answer is we need not. Sometimes we may have to give a higher loading dose. So this is contrary to the thinking that as the clearance decreases, we need to adjust the dose or decrease the dose. So why are we giving more loading dose? So loading dose which we give to these patients is to uh, attain the target therapeutic concentration as early as possible. So if this blue line shows uh, the time taken for a drug to reach a concentration level which is adequate or maintenance level after 24 to 32 hours. So initial 3 to 4 half-lives have taken for the drug to reach this level. But if you give a loading dose from the second T half only, the drug has reached the therapeutic target level. So the loading dose reason which we give is to get the therapeutic concentration as early as possible. So what happens in kidney disease, especially in AKI, there is increased volume of distribution. So volume of distribution as it increases, so the drug will be distributed more into the other tissues. So less of the drug is present in the plasma. So in such cases, we may have to increase the loading dose by 25%, especially for antibiotics. And the drugs which have that specific feature is beta-lactams, cephalosporins, and carbapenems, where the volume of distribution can be high in patients with AKI. So, so kidney dysfunction does not alter the loading dose. So the loading dose is defined by target concentration which we want, volume of distribution, and by the bioavailability. So if the volume of distribution is high, we need to give more loading dose. Coming to the maintenance dose depends on clearance. So if the clearance is less, if the clearance is decreased, more of the drug is retained in the body. So to prevent the toxicity, we need to decrease the drug dose or increase the dosing interval. Okay. So what will happen if you continue to give the drug at same dose, as I've already explained? So the black line here, so this graph shows the x-axis time, the y-axis drug concentration. The black line, the black graph shows the half-life of 4 hours. Blue line shows the half-life of 12 hours, and the red line shows the half-life of 24 hours. So as I've already told, as the T half increases, the time required to attain a steady drug level also increases. This is because 3 to 5 T halves are required to attain a specific maintenance drug level or a steady drug level. As the T half increases, it will take more time. So if we give a drug at same interval in patients with half-life which is increasing, the drug will get accumulated more and it will take more time to reach a specific steady state. So in the drug with the red line, it has taken 48 hours to reach a steady state. So as the T half increases, more time is required to reach a steady state, and the level which is attained is also very high drug concentration. So this may be toxic level. So what we do usually is we will decrease the dose of the drug and we will give at the same interval, or sometimes we will keep the same dose of the drug and will give at a increased time interval. So that depends on the pharmacodynamics of the drug, which I'll be telling. So coming to summary of what are the effects on pharmacokinetics. This is for AKI, CKD, and also kidney replacement therapy. As I've already told, absorption may decrease. In CKD, it may increase also. Volume of distribution may be same or it may increase. Metabolism is increased or usually decreased. Excretion is decreased. And in kidney replacement therapy, during dialysis, sometimes the drug may get cleared off. Coming to loading dose changes which we need to do in AKI and CKD. Loading dose should be same both in AKI and CKD patients. And sometimes if the volume of distribution is high, we need to give the higher loading dose. Coming to maintenance dose, if the kidney excretion is decreased by less than 50%, no change, as I've already told, both in AKI and CKD. If it is more than 50% decrease, we need to decrease the amount of the dose or frequency of the dose should be changed appropriately. And if we don't have data regarding the specific drug, we need to do the therapeutic drug monitoring to assist the dosage adjustment. And as I've already told regarding the drugs which are secreted by tubules and more of tubules when compared to glomeruli, we need to keep that in mind when giving drug to CKD patient. If the CKD is due to interstitial disease, the drugs which are secreted in the tubules needs to be adjusted. So what is the practical approach which we should follow in patients with CKD? So we should assume that creatinine clearance decreases with the proportional decrease in the GFR, and we assume that non-renal clearance is not affected, which is not the case usually. But we don't have any other option or a way to identify what is the change or what is the effect of CKD on non-renal clearance. So we blindly follow the GFR, that too the Cockcroft-Gault formula, which is not very accurate because we don't have any other option. We don't have studies with the newer GFR formulas, and we ignore usually the tubular elimination part, and we also ignore the cause of the kidney dysfunction. So what we do is very crude way of adjusting the dosages in CKD patients because of no data or no other way. Coming to AKI, so issues in AKI, as I've already told, fluid overload will be there, especially in sepsis or in AKI. So because of which there is increased volume of distribution, and the creatinine which we measure in AKI is delayed when compared to GFR. For example, we see many patients with urine output nil, but creatinine will be only 1. Does it mean that his kidney is normal? No. His GFR is less than 15, but creatinine takes 2 days, 48 to 72 hours to reach the GFR level. So creatinine will increase to more than 2 to 3 after 2 days only. Now the urine output is 0, but it will increase only after 2 days. So if we take creatinine in AKI patient, we will get an absolutely wrong value based on which we cannot adjust any drug. So what we can do in such cases, we can use the urine output. We can, in non-oliguric patients with AKI, we can measure the creatinine clearance in the 4-hour urine. But this is also dynamic. So we cannot continuously measure every 4 hourly what is the creatinine clearance and adjust the drug. And one more issue is the dynamic status of the patient. Minute to minute, AKI patient will be dynamic. Their volume of status may be different. Their GFR will be different. Their IV fluid intake will be different. Drug dose vitals may be different. And if in sepsis patients, we don't have data regarding the effect on the liver. Initial stages are fine, but later stages, as the shock develops, what is the effect on metabolism of the liver of the drugs, we don't know. So we don't have that data. So effectively, we cannot use CKD principles in AKI. So we cannot apply GFR value based, Cockcroft-Gault value based adjustment based drug adjustment in AKI patient. So here the clinical judgment is very important. So there is no doubt about loading dose. We need to give a normal dose or high loading dose based on the volume of distribution. But maintenance dose, initially, if the patient is sick, we need to give normal dosages, and we need to see the response of the patient. We need to look for the toxicity. And if we have any other information about the urine output, or if we can calculate the creatinine clearance in the urine, we can adjust based on that. In intermittent hemodialysis, during dialysis, drug get excreted. So what we usually do is we will give the drug after the dialysis, and we will tolerate the duration of dialysis with low concentration. But sometimes, if that is not uh, appropriate, we give a dose in between dialysis. So ultimately, therapeutic drug monitoring is the way to go, which will be the future, because we cannot individualize each patient what is happening with respect to their liver, intestine, kidney, the effect of those changes on the specific drug. So best is to monitor the level of drugs and adjust the dosages accordingly. And it is an accepted standard of care and key indicator for appropriateness of antibiotic use. So a few important things and controversies which I want to mention is about the chemotherapy, as our oncologists know more about this. So in patients with cancer, we dose the drug based on the creatinine clearance. So for example, if we take a person who has a body surface area of 1.73 meters square, we give bleomycin in that patient. The bleomycin is dosed at 10 units per meter square. So for 1.73 meters square, the dose is 17.3. So, and now we look at the creatinine clearance of this patient. if the creatinine, so this patient absolute kidney function, the creatinine clearance is 50 ml. But if we adjust this creatinine clearance to body surface area of 1.73 meters square, it will be same. So the modification in these two conditions is 70%, and same drug, same dose is given in two situations where the GFR is adjusted for body surface area and no adjustment for body surface area. But if we have a patient whose body surface area is more, like 2.07 meters square, and his GFR is creatinine clearance is 60, and if we adjust the with body surface area, the in body surface area indexed GFR is only 50. So for 60, there will be no reduction. For 50, there will be 70% of the dose. So if we use only creatinine clearance, we will give 43% more dose. In the same way, if the kidney function is less, and if the body surface area is less, we will decrease the dose. So what I want to tell here is, based on creatinine clearance without indexing to body surface area, uh, but for the drugs which are indexed for body surface area, there will be discordance in the drug dosing. But FDA still recommends to use creatinine clearance, and it has advocated to start using EGFR for body surface area adjustment for the newer drugs and in the studies. Still, it will take time for the change in the recommendations. Coming to antibiotic strategy, last few slides, last one or two slides. So antibiotic strategy, for antibiotics, we need to look at three important parameters. One is the peak to minimum inhibitory concentration ratio. This is the peak, this is the minimum inhibitory concentration. The ratio of this, so the drugs which are concentration dependent antibiotics will require maximum peak to be effective, example aminoglycosides. But for some drugs, we need to have the drug level just above the minimum inhibitory concentration. It need not go to this level. It should be just above the minimum inhibitory concentration, but it should be there for maximum time. So time above the minimum inhibitory concentration, this is called time dependent antibiotics. And another one is AUC by MIC, area under concentration by minimal, area under curve by minimum inhibitory concentration. So the antibiotics are, aminoglycoside is the concentration dependent antibiotic. So we want a peak. So here, so to keep the peak, if the clearance decreases, we will give the same dose, but will decrease the, we will increase the interval between the dosages. So we will give once a day or once in every 36 hours rather than giving small dosages. Whereas penicillin, cephalosporin, carbapenem, vancomycin, they are time dependent. So we will decrease the dosages of this drug and give at the same interval. So this we need to know while giving antibiotics, what type of antibiotics, what is their pharmacodynamic profile, and what dosages we need to give and at what interval. So the final slide. So stepwise approach, first we need to obtain, for any patient, obtain history and clinical information, use get creatinine clearance by Cockcroft-Gault formula, review the medications and individualize the treatment, and know the drugs which we need to adjust, and after adjusting we need to monitor for toxicity and drug levels, and based on that we need to adjust the drug. So in conclusion, CKD and AKI can cause complex changes in pharmacokinetics of drugs. Still many effects are not known. Creatinine clearance with Cockcroft-Gault formula is still used for dose adjustment in CKD. AKI in ICU and in septic patients require normal or higher than normal loading dose. Maintenance dose to be decided on clearance, therapeutic effect, and drug toxicity. And newer formulas are better than Cockcroft-Gault, but studies are required to study the pharmacokinetics of the drugs. Thank you.